Great. Well, good morning, everybody, and welcome. Can you all hear? Yeah. I think my title is What Do We Know About Injury and Mortality from Cycling? And actually, we know very little because England and the UK lag behind much of the world in terms of data and injury collection, especially much of Europe. We've got an appalling record. So while we know quite a lot about the deaths, we know very little about the injuries. And actually, of course, deaths are the tip of an iceberg. Deaths are at the top and then all the injuries underneath. But it's just important to remember that as in the rest of the world, injury is a very common cause of death and disability. We're not collecting good data throughout the NHS, and we really should be, and there are the possibilities of doing so, but we just need the political will to do it. That means our politicians getting behind it. And if we don't have it, the reason why data are important, it's the lifeblood of public health. We cannot actually monitor what's going on. We can't look at cause, we can't look at mechanism or location, and then we can't then actually put in prevention strategies. So we may have all these great ideas about prevention, but we can put them in place and we don't know actually what's happening. So a little bit about what we do know on the mortality side. These are transport-related deaths. And what you can see is that they've been falling quite steadily, actually since even before 2000, over the last 25 years. So all transport-related deaths have been falling, and deaths as a percentage of all injury-related deaths have also been falling. So that's the good news. So this is the number of deaths, 3,000 to around 1,700, and then a big fall again in percentage, which is on that side. The other good news is that deaths due to cycling in the UK have also been falling steadily from 1985 to 2012, from around nearly 300 in 1985 to just over 100, 110, and pretty static here in the last few years. So why is that? Is that because fewer people are cycling? Is it that cycling is safer? Well, these are some of the questions we don't really know. But this is quite interesting. You can see that all transport-related deaths have fallen, but that cycling deaths as a percentage of transport-related deaths are rising. So the big message is cycling deaths are falling overall, but they're rising as a percentage, so something's happening. So is it that fewer people are travelling with other forms of transport? Or is it something about the data collection? Or is it that there are actually more cyclists on the road doing more cycling? And these are the sorts of things we try and work out, and we've got very poor data on. And I'll come back to that in a minute. But this, in a way, shows you the pyramid effect. These tiny little green blobs are the deaths, tiny numbers of deaths. But underneath, you can see this pyramid of the red is the serious injuries, which appear to remain pretty, well, they're falling, but they're remaining pretty constant here. And the blue is the pyramid of the slight injuries. But there's an awful lot that we don't know, because these data either come from police reports or from the NHS hospital inpatient admissions. So these are the big messages. Number of transport-related deaths are falling, cycling-related deaths falling but have risen again, and deaths due to cycling have increased as a percentage of all transport deaths. We don't know why. We do try then to adjust for this fact. The big question is it that we've got fewer car journeys or more cycling and cyclists? And so we try and get a measure of the rates, the death rate. And one of the things is that it's very difficult to measure because we need an exposure. We can't just do deaths over the number of cyclists, because some of you cycle from Primrose Hill, some of you cycle from Brighton, so you're all doing different numbers of miles. So the exposure is calculated in per billion miles cycled. And what you can see again is that the good news is that injury and death rates are falling, and they remain pretty static. We've really done nothing to that in the last 5 or 6 years. Whereas the average distance that's being travelled is rising over time, miles per person per year, and the miles cycled in the UK is also beginning to rise. So here's the issues with the data. Stats 19 is routinely collected, police reports, collisions to police, but of course that's only the tip of the iceberg. Many of you will have accidents or injuries on your bicycle and you won't have reported it. The other source is NHS data, and that's the best source of data from A&E. and hospital admissions, but it's pretty appalling. We have nothing on mechanism, location or cause. So we'll maybe just have an injury. We have a national travel survey, which has been running continuously since 1988, but it only covers 8,000 households a year. Many in the household won't even cycle. Tiny sample size, and that's how we calculate the per billion miles cycled. So these estimates are very dodgy indeed, very, very ropey. And then we have a national road traffic survey where they've got automatic traffic counters where they just count the cycles as they go over. And that's pretty ropey too. So all in all, the data on injuries is pretty appalling and pretty ropey. And we need to improve it if we're going to do anything at all about injury prevention and injury monitoring. So we need better data on activity, cycling, mechanism of injury location. We need data on rehab. And the awful thing about this is that we've got perfectly good routine data sets that have been developed by the WHO, the College of Emergency Medicine, and we could be implementing this all across the UK, and we're not. In fact, only Wales is collecting good injury data as we speak. So I think that's one of our very big political challenges. If we want to get serious about injuries, then we will get serious about data. I'm going to actually stop here, because on the roundtables we can talk a lot more about the causes of hospital admissions, and you can see here that the big cause of data is collision with the car and pickup, but actually there's a lot of non-collision transport injury for cyclists as well, so falling off their bikes, skidding, etc. So that's a little bit of what we get. So I'm going to stop at this point.
Allyson, thank you. Manoj, Ramachandran.
Thank you. So I'm going to. So Alyson's had a look at a macroscopic look at trauma. I'm going to zoom in on a bit more microscopic about bone and joint injuries, which is what I'm an orthopedic surgeon. I'm also the CIO of this hospital, so I'm interested in informatics and how we collect data and what the strategy is for that. I'm the director of research in surgery, so I'm interested in performing surgery par excellence across all the surgical specialties. And we've got an amazing centre for trauma sciences that does a lot of research. You'll hear about that from Nigel. But I just want to show you some of the other things that we do too. We know that cycling, for example, injury from cycling can affect any parts of the body. If you look at the bones and joints, the really severe injuries are the top right. Fatal injuries we don't tend to really deal with. The minor injuries in the bottom right, which are collarbone fractures, soft tissue injuries, they come to accident emergency. Sometimes they may not even be reported. But the middle picture there on the right are the admissions that cause severe morbidity and long-term poor outcomes. That's what we're interested in. So we looked at our cycling admissions over the last year, between 2012 and 13. We've had 75 admitted with multiple traumas, mainly people in their 30s, mainly men, either falls or hit by a motor vehicle of some kind. And the injuries are multiple, but they tend to be of the collarbone, the spine, and the lower limb, particularly the tibia or shin bone. So that's interesting. That gives us a sort of overview, but that granular detail is missing. So we get some data from the ambulance services. They tell us where people are picked up, what time of the day, week, month, year. That's okay. We don't really understand the mechanisms around each particular major incident that we see. We've got, on the top right, we've got a hospital system where we record data for inpatients. The bottom right, we keep a database of all the traumatic injuries that we see. That's great. We've got a centre for orthopedics, similar to the trauma sciences, where we do a lot of research as basic science and translational. We have an informatics strategy, including innovative stuff. Barts and London Charity were amazing, got us some money through Canary Wharf Contractors, Cormac is here from them today, to develop an app that tells, so this is for hip patients who have hip surgery. They tell us what's happening to them before and after surgery, and they get exercises given to them, sent to them through their smartphones. And that's very interesting because you can communicate with your patients better, and you can get their narratives around any incident they're going through, whether that's surgery or an accident. And this helped us win sort of European awards and the British Innovation. That's okay, thank you very much. Thank you. Sorry? That's fine, we'll just carry on. So what's possible, Levine's, a solicitor's firm in the city, have got this as a live database from user-submitted data, so people who've had cycling injuries, and from Department of Transport figures showing you where all the hotspots are in London. You can see it gets hot as you go into the centre of London. And it's all around here where the fatalities and major injuries are happening. So this data can be collected in a much more interesting way. So what we'd like to do, one of the projects you read about in your binder, is to really look at the hows, wheres and whys of trauma, and really that qualitative research that's patient-submitted with narratives of why these things happen. We don't know these cyclists. Are they casual cyclists? Are they commuters? Have they been trained? Have they done cycling safety? What actually happened at the time of injury? Where did it happen? These are all interesting things that we need to find out. And that sort of granular detail will help us think about prevention, about policy, and about the cost. There we go, the cost of effect, cost to the health system of these injuries. That's all I'm going to say. Thank you very much.
Departments, so whether it be Home Office, Police, Trade, Education, Health. And because of that, nobody owns this baby, they're all passing it from place to place. And that's really very much reflected in the quality and the nature of the data and the fact that we know so little to inform prevention and treatment and rehab. And we actually lag behind the rest of Europe. And I think that's really important to remember that we're far behind. So everybody actually have picked up on that. And also, unless we have better data, we won't get better information about how we need to define mild, moderate, severe injury and also look at long-term outcomes.
I've just got three things to add to that. We do have some data, but it's not granular enough to really inform us on what the circumstances are surrounding each injury that we see. And the more we get from the patient, and even from sort of the rehab backwards, so the website that helps support patients after surviving a trauma, they could feed back right to the front end to tell us how these injuries happen. That would help us a lot. And ideally, we would move towards a sort of near real-time database that tells you exactly what's happening where. In London, but throughout that would be amazing.
But there's very fertile material here, which I think if people knew about would produce change. So thank you very warmly for your participation. Thank you, Barts Charity.